Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and joining us today for Healthline 3 conversation is Dr. Karen Berken, OBGYN with Willis Knighton Health. Good morning.
Hi, good to see you.
Yes. So you are local here in Shreveport-Bossier area with Willis Knighton. So tell us where you're located.
So our main office is at the Willis Knighton Bossier campus, which is in Suite 240, but it's on Hospital Drive, 2400 Suite 240. It's in the main hospital building, just on the second floor, so it's easy to get to.
Yeah, right off 220, right? Yep. Okay, cool. So today we are talking about something called uterine fibroids and how to manage that. There's surgical interventions, but first, uterine fibroids to me it just kind of sounds a little scary. So tell me and break that down what that actually means.
Yeah, so a lot of people have heard of fibroids or maybe have a friend or family member that's dealt with them or maybe had a hysterectomy because of them, but they don't know a whole lot about them. So they're very common. They're actually the most common tumor that plagues women. They're typically benign. Now there are some rare cases where they can become cancerous or they are cancerous, but they're typically benign. And it's estimated about 70% of women deal with fibroids at some point. Now only about 25% of those women actually have to seek treatment because of the severity of the symptoms, but the estimate is about 70% of women do develop fibroids of some type.
Wow, yeah, that's a pretty alarming number. Are people asymptomatic sometimes? Maybe they don't know they have them?
If they're particularly small or they maybe have just one or two, very small ones, then typically they can go through their whole menstrual life without having much increased symptoms or worsening symptoms from them.
Okay, gotcha. So usually with the uterine fibroids, you mentioned surgery. So you said 25% of those people have to seek treatment. So oftentimes maybe it's managed in other ways.
Yeah. So typically fibroids they happen in premenopausal females. Once somebody goes through menopause, typically they don't continue to grow or develop. Now they'll stay around and hang around if they've developed in those premenopausal years, but typically in those years when people are still having periods and these fibroids can be growing and developing, they'll develop a lot of symptoms, heavy cycles, painful cycles, even kind of mass effect symptoms. Fibroids sometimes can get very large to where someone almost looks 9 months pregnant because of fibroids. And so they can press on bowel and bladder and cause other symptoms as well. And they also can cause anemia if someone's periods are just that heavy. So lots of females deal with these symptoms, and if they seek a doctor's treatment and diagnosis, then oftentimes we'll try to start minimally invasive or with a non-surgical option first, because oftentimes that will take care of the symptoms of fibroids unless they continue to grow and cause more of those severe symptoms later on.
Okay, makes sense. Yeah, so how does someone develop a uterine fibroid?
So risk factors for them are going to be some genetic factors, so definitely they do run in families. There's a little bit of a ethnic risk as well. For example, African American females have about a 2 to 3 times increased likelihood of developing fibroids compared to a Caucasian counterpart. Also, African American females typically deal with fibroids at younger ages. They typically get bigger, more anemic, more severe symptoms. So there is definitely a genetic and ethnic risk factor there. Also, obesity, chronic hypertension, which those are risk factors for lots of different ailments, but obesity, chronic hypertension, and then of course they plague premenopausal females. And then actually the more babies you have and the closer together you have children, that's actually protective a little bit against fibroids. So if you haven't had children or have had maybe just 1 or 2 or a great amount of time between pregnancies, that's an increased risk factor for them as well.
Very interesting. Okay. And so when you're talking about the fibroid, you mentioned it's like a benign tumor, right? Or a tumor within the uterine wall, if you will?
Yes. So they're typically benign. There is a rare case of fibroid called a leiomyosarcoma. I know that's a long word, but it's a sarcoma, which is a typically aggressive fast-growing type of cancer. There's lots of different types of sarcomas throughout the body, but in the uterus, related to fibroids, a leiomyosarcoma is the malignant version, but the vast majority of fibroids are benign, and they're tumors or growths in the muscle of the uterus or either on the outside or the inside of the uterus. So they're basically composed of smooth muscle cells and just dense fibrotic tissue. When you look at them, to the naked eye, they look kind of like golf balls. They're kind of these white, well circumscribed kind of spherical tumors. And they can grow on the outside surface of the uterus, within the cavity of the uterus, or kind of built into the wall of the uterus itself.
Okay, and you mentioned a lot of the typical symptoms that someone would have, but it sounds like there may be typical like PMS symptoms as well. So how does someone know if they have developed these fibroids?
Yeah, well, they're sometimes hard to pinpoint, and a lot of times people will delay seeking treatment because they think, oh, maybe this is just what my period is like. Maybe it's this heavy or this painful, and that's what everybody deals with. And so it's not until it gets to an extreme nature that they'll actually come in and seek treatment. Of course, if you come to a regular annual exam with an OBGYN as part of your exam and your physical exam, we're feeling for the size of someone's uterus and asking questions about the heaviness and the pain associated with periods. And so sometimes someone comes in for a routine annual visit, and then it becomes a problem visit because we identify an enlarged uterus or menstrual cycle issues or pain, associated with fibroids. So you can typically feel them on an exam, but a lot of times people do come in and seek treatment or report heavy cycles, soaking through multiple pads, having to wear pads and tampons at the same time, soiling their clothes, or just significant pelvic pain, or sometimes constipation, bladder issues or bladder pain just from a very enlarged uterus, just putting basically pressure on the surrounding structures.
Gotcha. Yeah. Okay. Put a pin in that, and we've got our first viewer calling in. Melinda, thanks for joining us. And what is your question for Dr. Berken?
It's two parts, if you don't mind. What's the difference between uterine fibroids and polycystic ovarian disease? And is it an autoimmune disease or an autoimmune reaction?
So the difference between polycystic ovarian syndrome, or PCOS, and fibroids is basically fibroids are benign tumors in the uterus, whereas polycystic ovarian syndrome involves the ovaries. So that's where you have multiple cysts of various sizes that form on the ovaries. So one is a uterine issue, one is an ovarian issue. Symptoms can be fairly similar. People with PCOS often have irregular cycles, sometimes heavy bleeding, sometimes pain from the cysts. And when you're talking about the abdomen or the pelvis, all the structures are so close to one another that oftentimes it's difficult without a good exam and without an ultrasound to really tell where those symptoms might be coming from. And then the second part of your question was about autoimmune conditions. So there's definitely an increased risk of fibroids with autoimmune conditions, other things like chronic hypertension, diabetes, obesity. All of these conditions can be interlinked. But fibroids in and of themselves are not an autoimmune condition, or not caused by autoimmune conditions like what you would think as sarcoidosis, lupus, rheumatoid arthritis, things like that. Anything else?
Can you have an autoimmune reaction to the fibroid?
So you can certainly, because they cause a lot of inflammation, basically any autoimmune condition increases your body's level of inflammation, no matter what that condition is. And so you can certainly have increased inflammation around your uterus, which can potentiate, flares and other symptoms as well.
Well, thank you.
You're welcome.
Yeah, thanks, Melinda, for calling in. And if you're just joining us and you have a question for Dr. Berken, we are talking about uterine fibroids and ways to manage that and risk factors and all that good stuff about the specific topic. You can give us a call, 318-219-4569, and we'd be happy to take that call and answer your question. Yeah, okay, so with the fibroids, is this something that, you mentioned it happens in premenopausal women. What about, is there a connection with endometriosis as well, or is it kind of just something completely separate?
So it's fairly separate. Endometriosis is another common condition that causes pelvic pain. So again, just like from our viewer, PCOS, polycystic ovarian syndrome, another common cause of irregular cycles, painful cycles. And so it can be difficult to delineate between those three ailments without, a detailed physical exam, and a transvaginal ultrasound is the main way to identify not only the location, but the size and the number of fibroids, because some people can have one large fibroid, they can have several small fibroids, and as I mentioned earlier, they can grow significantly, slowly over time, typically, to where the uterus gets quite enlarged.
Okay. Well, Kathy, thanks for joining us, and what is your question for Dr. Berken?
Yes, I recently went through menopause, and I have been diagnosed with fibroids. And I was wondering if it would be just safe to live with them and don't do anything about them.
So fibroids, they typically grow and develop during those premenopausal years, but if they have grown and developed and then you end up going through menopause, they typically don't go away. They might not grow anymore, they may shrink a little bit, but they're still there. And so it kind of depends on your symptoms. Obviously, if you're postmenopausal, you're not having periods anymore, but if they're large enough, you may have other symptoms. Different constipation issues, bladder issues, or just pelvic pain, just from the mass effect of the pressure, from fibroids on surrounding structures. So if you have any of those symptoms, then it's still very common to seek interventions for them, whether that be medical or surgical.
Okay. What if you don't have any symptoms?
If you don't have any symptoms, then typically I would just leave them alone. I would recommend going to your annual visits just so that you have an OBGYN just once a year, making sure they're not growing in size or causing any issues. Like I mentioned before, there can be some rare cases where a fibroid is not benign, it's malignant or cancerous. Fibroids don't typically turn into a malignant, or benign fibroids don't typically turn malignant. They start malignant basically from the get-go. And they typically grow very rapidly and cause a lot of symptoms very quickly. So if fibroids have been there for years and they're not causing any issues, then they're unlikely to in the future. So you could just go to your annual visits and have your doctor keep an eye on them.
Okay, thank you.
You're welcome.
Yeah, thanks for your question, Kathy. And if you're just joining us again, that number is 318-219-4569, right there on the bottom of your screen. So you mentioned premenopausal, it can progress or grow in some ways. Is that due to the hormones?
Yes, it is. It's typically due to particularly estrogen, which also fuels PCOS and endometriosis and lots of other conditions, but typically that hormone will cause the fibroids to grow very slowly over time.
Gotcha. Okay, we have another caller, Jasmine. Thanks for joining us, and what's your question?
Hi, doctor. I just had a surgery in October for fibroids, and it was my third surgery. And actually, I had a hysterectomy 25 years ago, but they told me that they appeared again, even without having uterus, and that it came from muscle tissue surrounding it, or I really don't really understand, and it took a long time for them to diagnose it as the same fibroids that I've had two surgeries for. I had a myomectomy and then a hysterectomy, and now this surgery. But my concern is that them returning again, even without, a uterus.
Right. So that situation is a little bit more rare, but it is possible. Mainly, it sounds like you've had kind of battled fibroids for a while. You had some significant ones. Myomectomy is a surgical procedure where you don't remove the uterus, you just go in and remove the fibroids, but leave the good, healthy uterine muscle intact. That a lot of times we do that for fertility preservation. And then eventually you ended up having the hysterectomy. And there are instances where maybe there's a lot of scarring in the abdomen, and in order to not damage any surrounding structures, sometimes during a hysterectomy, the goal is to remove everything, but sometimes because of scar tissue and whatnot, there might be a very small piece of uterus that you actually have to kind of leave behind because it's too risky to remove that because of some of the surrounding blood vessels or structures. And so in that case, even if one cell of the uterus is left behind, that cell can, over time, develop and turn into fibroids.
So it can still come back again?
So when you had your hysterectomy, did you have your ovaries removed, or do you still have your ovaries?
I had everything removed. That was 25 years ago.
You had everything removed. Well, so typically, once your ovaries are removed, then your hormone goes with your ovaries. So you typically don't have very much native hormone left. Now, hormone replacement therapy contains estrogen, and also other tissues in the body do make small amounts of estrogen. And so there is the potential that a fibroid could return even after having a hysterectomy, although very rare. And if you had a surgery or had developed fibroids after a hysterectomy, hopefully when they went back in surgically to remove anything that had developed, they were able, with some of the newer technologies, robotic surgery, things like that, maybe were able to remove any residual uterine tissue to where you wouldn't have to deal with them in the future.
Well, thank you, doctor.
You're welcome.
Yeah, and if you're just joining us, we are talking about uterine fibroids, and so if you have a specific question to that, give us a call, 318-219-4569. And so we were talking about, you mentioned maybe the myomectomy, or you just removing the fibroids, and that helps maybe preserve fertility. So is this something that is an issue that women may be facing that could, inhibit their fertility?
It certainly can, depending on where the fibroids are located. Sometimes a fibroid can grow in the middle of the uterine cavity or right over where the fallopian tubes, spill into the uterus. And so absolutely that could obstruct and prevent conception and pregnancy. And so typically when someone does have fibroids and you get an ultrasound, we are able to kind of characterize the location, the size, and get a pretty good gauge for if they're in a position that will affect their fertility or not. And then in that instance, there's lots of options. Typically, first-line treatment to just control symptoms of bleeding would be different contraceptive options, birth control pills, IUDs, things like that, even some non-steroidal anti-inflammatory medications that basically can reduce the blood flow and reduce some of those symptoms. But if a fibroid is too large, causing lots of pelvic pain, or we have concern about fertility and the person is still interested in future pregnancies, then there are various surgical options that are not a hysterectomy but can actually preserve the uterus.
Gotcha. Okay. Yeah, so there's definitely options to where you don't have to immediately think hysterectomy, oh my goodness, I have to this is the only option for me.
Right.
And like you mentioned, lots of technology and lots of advancements in the last several years. So I know that you wouldn't be performing the surgery, right? You were kind of helping diagnose and figure out if this is what's going on, right? And then you refer to.
So they would come to my office and we would do an exam and an ultrasound, and then the vast majority of the treatments, surgical treatments for fibroids, most OBGYNs do.
Oh, okay.
And so that's one of our, surgical options. And so I do myomectomies and robotic myomectomies and whatnot. Some of the other treatments out there are, there's something called a uterine artery embolization. That's something that's not really recommended to preserve fertility. But that is a treatment that typically an interventional radiologist would do. So I don't do that one.
Okay.
But you basically ablate or block off the major blood supply to the uterus, and then that starves out the fibroids and really causes them to kind of devascularize and shrink and regress. So that's a treatment that's not done by myself or typically by an OBGYN, but we can do hysteroscopic removals of fibroids or hysteroscopic myomectomies. That's where if the fibroid is in the cavity of the uterus, we don't actually have to make any abdominal incisions. We can actually go in with a camera through the cervix into the uterus and actually shave or remove the fibroid that way. So that's called a hysteroscopic myomectomy. And then there are other surgical procedures. So there's something called a radiofrequency ablation, which is where you go in laparoscopically and you essentially launch various prongs into each fibroid, and you cook it essentially with radiofrequency, and you kill it so that it shrinks down. It won't completely disappear, but it'll become inactive and shrink down. And then there's various types of laparoscopic robotic myomectomy. So making small incisions in the abdomen and actually going in, you make small incisions on the uterus over where the fibroids are located, and you actually remove each individual fibroid and then kind of sew all the incisions back together to kind of piece the uterus back together to a more normal appearance and size. So that can be done laparoscopically or robotically. I like to do it robotically just because you have very, very fine, small instruments that can rotate 360 degrees, which is a lot more than the human hand can. And so I control the robot, but have basically these robotic instruments that allow really, really fine motor skills. And so you can get the best cosmetic effect and not injure the good part of the uterus that you're trying to preserve. And then if fibroids have gotten extremely large, sometimes the only option is what's called an open myomectomy, which is where you're making a bigger incision, either a C-section type incision or even a vertical midline large incision where you go in and remove the fibroids that way. Typically the reason for that is if they've gotten so large that there's just no other way to get them out. Through small port incision sites.
Gotcha. Okay. And so, if someone is, I know that there's a spectrum. I'm sure, like depending on the surgery. It could be a bigger surgery, a bigger operation, and that's going to determine how your post-op is going to be. So, let's say someone is preparing to have one of the interventions, I guess, for uterine fibroid. What does the post-op typically look like? I know it's a spectrum.
It's very dependent. So if you have the surgery done hysteroscopically, the recovery is actually pretty straightforward and minimal. You might have a little bit of bleeding afterwards, maybe a little bit of cramping, but typically can return to your normal daily activities and work from a day or two, typically not much downtime at all. Now, if you have a robotic or laparoscopic myomectomy, it's a little bit more involved. You are having some incisions placed, very small incisions, but some incisions placed on your abdomen. It is an abdominal surgery. So typically I tell patients for a recovery from a myomectomy, it's about 1 to 2 weeks of downtime, basically avoiding heavy lifting, strenuous exercise, probably avoiding, work if you have to do anything strenuous at work. But then after those first 2 weeks, typically people feel pretty good and are back on their feet and can resume all their normal activities.
Awesome.
An open myomectomy is a much bigger surgery typically, and it's requires about a 2-night, minimum about 1 night, but typically about a 2-night hospital stay, and then 6 weeks of downtime.
Okay, yeah, so definitely a spectrum there, but that's something that's very individualized that you're able to talk with each patient about. So, Linda, thanks for joining us, and what is your question?
Yes, I am actually postmenopausal. I've had uterine polyps removed a couple of times. They did not call it fibroids. They actually called it polyps. But I had been doing hormone replacement therapy using the BioT pellets, and I was cautioned to probably stop doing the hormone replacement therapy because it could be related to the uterine polyps that I was having. I just wanted to hear your opinion about that.
Yeah, absolutely. So there's more than just fibroids that can develop in the cavity of the uterus. Polyps are probably the next most common thing, or even sometimes in some cases more common than fibroids. Polyps are basically just overgrowth of tissue. So the same tissue that makes up the lining of the uterus that people shed monthly during their menstrual cycle can develop thickened areas. They almost kind of, for lack of a better word, kind of look like mushrooms kind of growing on the top of the lining. And they bring in extra blood flow. They're very friable, meaning any disruption of them can cause them to bleed. And so they are a common cause of menstrual issues, both pre and postmenopausal. Typically they're hormone driven, estrogen driven, and so if someone has gone through menopause, gets on hormone replacement therapy with estrogen, and then comes into the office saying that they've had a period return after many years of not having one, that's a red flag, obviously, so we start a workup for that, one thing being an ultrasound. And if we do an ultrasound, we can typically see a thickened lining. After menopause, that lining should be very, very thin. And so if it's above a certain millimeter thickness, then that's a red flag. We can also see if there's fibroids or polyps in the uterine cavity. And then in that instance, we would recommend doing some type of either biopsy of those polyps or removal, surgical removal, which you can do hysteroscopically as well. If that is something that you have dealt with, typically the recommendation is to stop the estrogen hormone replacement therapy, because those hormones are what ultimately is fueling the growth of these polyps and causing problems. Polyps are often benign. They can also become cancerous and can lead to uterine cancer. So the main reason to avoid hormone replacement therapy if you've had polyp growth is to prevent cancer. And then anyone that has a uterus that's on estrogen replacement therapy should be on progesterone as well. Progesterone is protective against polyps from forming and from that increased thickness of the lining. Now, if you've had a hysterectomy and your uterus is gone, you don't need the progesterone anymore. But the estrogen is the hormone that you feel like you need and that helps you, but the progesterone is just protective against the polyp growth in the lining.
Very interesting. Okay. Well, let's say we have just a couple minutes left. Let's say someone at home is maybe having some of those symptoms that you mentioned earlier in the conversation, and maybe, you know, they haven't scheduled their annual appointment. Where can someone find you, and what are those questions that maybe someone needs to ask at that appointment?
So they can certainly call the office. Our number is 318-212-7931. We're at the Willis Knighton location at Women's Health Associates, which is 2400 Hospital Drive, Suite 240. So you can definitely call us or, you know, any local OBGYN. This is a very common issue. Painful cycles, heavy bleeding are two of the most common complaints that we typically hear from patients, and depending on if someone's pre or postmenopausal and what we find on ultrasound and on exam definitely warrants further treatment sometimes.
All right. Well, great conversation. Thanks, Karen, for Dr. Berken for being here. And if you missed this will be on our website at ktbs.com/podcast. Thanks for joining us. Great. We had